Check, check.
Good morning, everyone. So, we're starting our second day, and we start the day with chalk and chisel. It's meant for all the PGs, so for the few of us assembled here, in the interest of time and not delaying the other sessions, we'll start with our first talk. But before we start, I'd like to invite our chair and co chair, Dr. Rama Devi and Dr. Manju Reddy, on the stage, please.
Dr. Elizabeth is there? Dr. Elizabeth?
Ma'am, we're starting with Dr. Lynette. So, I welcome our first speaker, Dr. Lynette, and her topic is abnormal pupils, the big, small, and everything in between.
Very good
Just-
morning to all of you. I'd like to start this session because it's a teaching session. And, looking at the emptiness of the hall, it's like brain drain. Nobody wants to come to teaching sessions anymore. and I don't know, it's like very disheartening to see that only 10 people are there in the auditorium. However, it's a lovely day outside, and we just have to do the thing by teaching. All of you are welcome. I hope more people join. Thank you.
Good morning. Since it's a Guru Purnima, I want to all of you to start with a prayer to Guru. Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha. Good luck to all of you. Welcome.
So, good morning, everybody. We'll be discussing about pupil today in a very short way. So, let's start with the normal anatomy of the pupil, because I'll be talking about the different abnormalities in the size of the pupil. We'll be just discussing about the muscles which are there in the pupil, which is the one is the sphincter pupillae, which is the circular muscles that you see in the center of the pupil, and it's supplied by the parasympathetic nerves. And the circular muscles, the radial muscles which are seen little away from the center of the pupil, those are the dilator pupillae, which help in pupillary dilation and is supplied by the sympathetic pathway. So if you see the histopathological slide on the side, you can see that there are you can see the radial fibers away from the center and the circular fibers right in the center of the pupil. Coming to the pupillary pathway in a short way, we have the first order neurons which come from the retinal ganglion cells, and it goes along the optic nerve, the chiasma, optic tract, into the lateral geniculate body, and then it synapses into the pretectal olivary nucleus. The second order neurons go from the pretectal or olivary nucleus to the Edinger-Westphal nucleus. There is crossing over of fibers here in this second order neurons. From the Edinger-Westphal nucleus, it further goes into the efferent fibers go along the oculomotor nerve, that's the third nerve, and it synapses into the ciliary ganglion, and you have the post-ganglionic parasympathetic supply going into the sphincter pupillae along the short ciliary nerves. The sympathetic pathway again has three order neurons. The first one arises from the hypothalamus, goes along the brainstem and synapses in the cervicothoracic area from C7 to T2. The second order neurons start from here and they synapse at the superior cervical ganglion, which is present at the bifurcation of the carotid artery. And the third order neuron is a long course which goes along the internal carotid artery and then through the supraorbital fissure, cavernous sinus, and into the orbit to supply the dilator pupillae along through the long ciliary nerves. So how do you assess the pupil? You look for the size of the pupil, you look for the number, you look for the shape of the pupil, and finally the most important one is the reflexes in the pupil, which will help you to assess the parasympathetic nerve supply and the sympathetic nerve supply. Now patients who have abnormal pupil size usually come with these symptoms. They usually have glare or light intolerance or hazy vision, near vision problem, depth perception problems, headaches, diplopia, or deviation of the eyeball, or ptosis. So if any patient comes to you with any of these symptoms, you have to specifically look for any pupil abnormalities. Now what are the different causes of big pupil? These are the most common causes: the third cranial nerve palsy, Addy-Stonic pupil, post-traumatic mydriasis, cocaine overdose, and any poisoning with datura or belladonna which has atropine in it, and dilating drops can cause big pupil. So we will be discussing a few of these topics. First we will discuss about Addy-Stonic pupil. It is a post-ganglionic parasympathetic denervation. So it's usually seen in young adults. Females are more commonly affected than males. And if you see a patient in the dark, one pupil is usually larger.
But if you put a cholinergic substance like a 0.1% pilocaine, it'll constrict, meaning it is super sensitive to cholinergic substances. Along with this, the another feature of Addy's tonic pupil is that you can see light near dissociation, meaning that when the light is put on the pupil will not constrict. But if there is a near, if you try to do accommodation for the patient, you will see that there is constriction of the pupil, meaning there is a light near dissociation. Now this is a feature of acute Addy's tonic, but in cases of chronic tonic pupil, you will have a bilateral or unilateral small pupil. An associated systemic feature of Addy's tonic pupil is that you will find that there is reduced deep tendon reflexes. You can see in the image that the patient in image A, there is a slight dilatation of the left pupil, and when there is dim light, there is increased anisocoria, showing that there is a problem in the sphincter pupillae in that eye. On near reflex, if you see, there is constriction of both pupils, meaning that there is a light near dissociation. And if you put 0.1 pilocarpine, this patient's pupil will constrict, meaning there is hypersensitivity to pilocarpine or cholinergic. What are the other causes of light near dissociation? Argyll-Robertson pupil, which is an infectious cause, pinealoma, stroke, third nerve aberrant reinnervation, and Perinaud syndrome. Now, what are the different causes of small pupil? Small pupil causes are Horner syndrome, Argyll-Robertson pupil, pontine tumors or hemorrhages, opiates, organophosphorus poisoning, and drugs like pilocarpine or physostigmine and neostigmine. We'll just look into Horner syndrome in little detail. The typical presentation of a patient is the patient will have a dilatation lag, meaning if the patient is going from a light room to a dark room, there will be lag in the dilatation, meaning there is a problem in the sympathetic pathway. The dilator pupillae is unable to dilate in the same way as the normal pupil. So now what is the diagnostic test for a Horner's pupil? If you apply 4% cocaine to the abnormal eye, it will dilate, but it will be lesser than the normal pupil. Whereas apraclonidine, if it is used, it will immediately dilate the affected eye, whereas the normal eye will not be dilated. So hydroxyamphetamine test is done to differentiate or localize the site of the Horner's syndrome, which can be preganglionic or postganglionic. Preganglionic lesion, if it is there, the postganglionic fibers still can act with the help of hydroxyamphetamine. So there will be dilatation of the pupil if you put hydroxyamphetamine in a preganglionic lesion. But if there is a postganglionic lesion, there will not be a dilatation even after hydroxyamphetamine. Coming to Argyll-Robertson pupil, this is usually patient has a bilateral small pupil which does not react to light but can react to near accommodation. So in just coming to a summary, whenever you have an anisocoria, you have to evaluate the patient in bright light and dim light. If the anisocoria increases in bright light, there is a defect in the parasympathetic innervation or the sphincter pupillae. While if the anisocoria increases in dim light, you have a defect in the sympathetic innervation. This is an algorithm which you can follow to evaluate for anisocoria. I would also like to add some conditions where you have an abnormally shaped pupil, which is the first image shows a iridodialysis and shows a D-shaped pupil. Second one shows uveitis, irregular shaped pupil. Third one is a surgically done iridectomy. Fourth is a acute angle closure glaucoma. Fifth is a coloboma, and sixth is a adherent leucoma.
Thank you, Dr. Lynette. we'll try and keep the questions. So if any of the postgraduates have any questions, please keep it, make a note of it. At the end of the session, we'll take the questions when we have time. Moving on to the next topic, I welcome on stage Dr. Soumya for her talk on how to approach a case of keratoconus.
Last one, last one.
Good morning, everybody. One of the most common corneal disorders that we encounter is keratoconus. One of the commonest ectatic disorders that we all encounter in our clinics is keratoconus among the other ectatic disorders. The other ectatic disorders are pellucid marginal degeneration, where the ectasia is inferior in the cornea. Keratoglobus, there is global thinning and ectasia of the entire cornea. By definition, this is a classic textbook definition where it is bilateral, progressive, non-inflammatory ectasia thinning of the central or the paracentral cornea. In my previous classification of ectatic disorders, I did not include post-LASIK ectasia because it is iatrogenic induced, and these are all on the virgin corneas which have these non-inflammatory ectatic process. And coming to the history, it was described as early as in the 18th century. This clinical entity was described by the British physician. Any patient who would present to a clinic with frequent eye rubbing associated with itching, blurred vision, frequent change of glass, this is the clincher. The other conditions do not come with this. They usually come with the history of frequent change of glasses, photophobia, glare, halos, poor best spectacle corrected visual acuity, and frequent headaches. And you have to look at the other ocular associations whenever patients with such symptoms come. VKC is very common, vernal keratoconjunctivitis. The other uncommon disorders are retinitis pigmentosa and Fuchs dystrophy are also associated with keratoconus. The clinical features can be brought, whenever such a patient presents to us to the clinic, how do we go about, like any other regular patient, we do the routine examination, retinoscopy, and the clinical features. Here, the clinical features, we can broadly classify them as external examination and on slit lamp examination. The three characteristic clinching diagnostic signs of keratoconus are Munson's, Risutis, and oil droplet reflex of Charlet. I'll go one by one. Munson's sign, what is this? It's a V-shaped protrusion of the lower lid in down gaze. This is a very subjective phenomenon, more commonly pronounced when the keratoconus is advanced. Otherwise, in early keratoconus, you might not be able to see this sign. The second one is the Risutis phenomenon. Whenever the torchlight is thrown temporarily on the limbus, you see an arc-like illumination on the nasal limbus. This is the normal feature seen in a regular individual. Whereas this patient, pointer, can be seen? Okay, anyway. Whenever the light is thrown from the temporal limbus, there's an illumination which is not arc-shaped, but it is in a sphere head or an arrow pattern which is seen on the nasal limbus. This is called the Risutis phenomenon. All these are external clinical signs which are elicited by the torchlight. And this is the oil droplet reflex of Charlet. When we do a distant direct ophthalmoscopy, the cone projects like an oil droplet. This is a sign seen on distant direct ophthalmoscopy done at 25 centimeters. Then coming to the slit lamp examination, we have all these signs. The Fleischer's ring, prominent corneal nerves, thinning and ectasia, Vaux striae, apical or subepithelial scarring, which is seen on the cornea. Coming to the Flescher's ring, it is best seen, early Flescher's ring is best seen on cobalt blue filter, or even a red free filter or the green filter can be used. It hallmarks where the extent of the cone is. It is the deposition of iron or the ferritin particles which are deposited in the epithelium, the basal layers of the topmost layer, that is the epithelium. These are the prominent corneal nerves which are seen very commonly in case of keratoconus. It can be seen in a normal individual also, but a short thing in cases of keratoconus. The corneal thinning and ectasia, which is pronounced here in the center, you can see, when you see, look at the slit lamp examination, there is thinning as well as ectasia, maybe not in a 2D picture. Of course, thinning definitely can be made out. Vogt striae, these are fine parallel lines seen. We have to note that they're seen at the posterior stroma level and not the Descemet's level. These are fine oblique lines, fine vertical or oblique lines which are seen. And then this is the classification, Amsler-Krumig classification, where you'll find it in any of the textbooks. I'm not going into the the details of it. They are classified from stage 1 to stage 4. There's a classification based on keratometry. Less than 48 is called mild, and the severe one is called more than 54 diopters, and the K-metry, and this is based on the morphology. And the most important thing is why we have to diagnose a case of keratoconus is for the treatment algorithm. First of all, we have to document whether there is progression or there's no progression of keratoconus. If at all there's progression, how do we document progression? One is by your retinoscopy, slit lamp examination, and topographic features, which I've not touched upon here. If there is progression, we go ahead with collagen cross-linking, and post that we do a visual rehabilitation either with glasses or contact lenses. If there's no progression, the vision is fairly well controlled and there's no topographic changes, the vision is good with glasses and contact lenses, we continue with contact lenses and glasses and keep them on a frequent follow-up, or if the patient wants, they can have an phakic IOL. If the patient is intolerant and there's an eccentric cone and there is progression and they're intolerant towards RGPs, we can, treat them with Intacs. Or if the cone, progresses so much, there's an advanced keratoconus, finally they'll end up with PK and DALK. The main clincher here is PK is done when there is Descemet's level scarring due to hydrops, and DALK is done in other cases where there's no scarring. Thank you.
Very big topic, covered nicely, madam. Thank you very much. And this thing is very important for postgraduates because they'll have in exam cases as well as Pentacam to read and then answer in the Viva. So maybe you should concentrate on this also.
Thank you for that illuminating talk, Dr. Soumya. Next, I'd like to call Dr. Arun Bhatti for his talk on proliferative diabetic retinopathy. Please welcome on stage, sir.
Good morning, everyone. I'll be talking about proliferative diabetic retinopathy. So before starting my presentation, I would like to show you a fundus image, not showing up.
Has any questions, please write it on a piece of paper. You can pass it to us, or directly stand up. The mic will come to you, and you will be able to ask your questions directly to the speakers concerned. But what saddens me is, see, today is something that, free of any hassles of sitting in a classroom. People are just not taking advantage of these sessions. I don't know, Rama was saying we should have made it free. To run a conference, you don't know how much effort and money it takes. So when it is a session like this, I would have loved it if PGs could have participated. patient is called chalk and chisel, but I want to have a hammer also. It's something that I've never, sorry for being so, aggressive about these things, but it's not like you can be a good teacher. Either there's too much work or no teaching, and too much teaching or no work. That kind of institutions we have today.
Good morning, everyone. Sorry for the technical glitch. So I'll be talking about proliferative diabetic retinopathy. Before I start my presentation, I would like to show you a fundus image of a diabetic patient. So this patient, this fundus looks very innocuous. There are not many changes seen in the posterior pole. You can see few hemorrhages, few hard exudates on the retina. However, this is a case of proliferative diabetic retinopathy. It's a case of featureless retina, which is confirmed on fundus fluorescein angiography, where you can see capillary non-perfusion areas in the inferior retina, and at the junction of the avascular and vascular retina, there are some leakages seen, which is suggestive of NBE. This is a case of PDR. So all the PDR cases should be identified, and then they should be treated so that we can prevent blindness. So diabetic retinopathy is a major cause of preventable blindness. DR affects almost 30% of the diabetic mellitus patients. Out of these, around 9% of these diabetic retinopathy patients are PDR cases and need to be identified and treated. Coming on to the risk factors, we all know that there are non-modifiable and modifiable risk factors. So the duration of diabetes, hyperglycemia, hypertension, increased lipids, all these are the risk factors. So the correlation between these risk factors and diabetic retinopathy has been established by various clinical trials. I'll be not going into the details of this. So before we start the local management of proliferative diabetic retinopathy, we have to first control the systemic parameters. So control of diabetes and hypertension and hyperlipidemia is of utmost importance. So diabetic retinopathy is classified into mild, moderate, severe NPDR and PDR. So I'll be focusing on PDR. So PDR is an advanced stage of diabetic eye disease, which is characterized by formation of new vessels on the retina, on the disc, which extend along the retinal surface into the vitreous cavity and can significantly lead to risk of vision loss. So all these new vessels are because of a state of relative retinal ischemia. The natural course of PDR follows the four fundamental process. So basically there are new vessels which are seen, which are formed initially, and followed by there is fibrous proliferation along with these vessels. So there is a fibrovascular component which comes up. This fibrovascular component gets adhered to the posterior vitreous surface, and then there is contraction of the vitreous, which leads to fractional retinal detachment. Over the period of time, the vascular component regresses. However, the damage by that time is mostly done. So PDR is classified into early PDR or non-HRC PDR, PDR with HRC or high-risk characteristics, and advanced proliferative diabetic retinopathy. So early PDR is when there are new vessels which are small in size, less than 1/4 disc diameter, which does not meet high-risk characteristic criteria. So this is a case of early PDR where you can see a small NVE, and this is a case of pre-retinal hemorrhage without any NVE. These are all images of early PDR. The high-risk characteristics are if there is a neovascular NVD of less than 1/4 disc diameter with vitreous hemorrhage, or if there is an NVD of more than 1/4 to 1/3 disc diameter without vitreous hemorrhage, and if there is a big NVE of half disc diameter with or without vitreous hemorrhage. So this image shows a massive NVD, more than 1 disc diameter. It's a high-risk HRC PDR. So how to examine the patients? So first of all, we have to do both indirect ophthalmoscopy and slit lamp biomicroscopy. So slit lamp, before doing slit lamp biomicroscopy, a good IDEO or indirect ophthalmoscopy examination will give us a overview or a bird's eye view of the retina. Then slit lamp biomicroscopy can be used to magnify the certain areas which we need to focus on. So what are we looking in the fundus in such patients or in diabetic patients? We are looking primarily for neovascularization. So NVD is defined as new vessels on the disc or within 1 disc diameter of the disc, or in the vitreous cavity just anterior to the disc. Neovascularization elsewhere are new vessels other than the NVD area. The most common site or quadrant of NVE proliferation is as the superior temporal quadrant. So NVE is classified according to OCT angiography into type 1, type 2, and type 3. Type 1 is arises from the venous side, type 2 arises from the capillary plexus, and type 3 arises from the intraretinal microvascular abnormalities. Type 1 is characteristically tree-shaped pattern, type 2 is octopus-shaped pattern, type 3 is a C-fan pattern. So OCT A and fundus fluorescein angiography is very important to confirm the diagnosis of PDR. Once we have a diagnosis of PDR, we can, the management strategies are laser photocoagulation, anti-VEGF, and surgery. So indications of PRP are all the cases of proliferative diabetic retinopathy, cases with NVG or neovascularization of the iris. Sometimes early PRP is considered in severe NPDR cases when the regular follow-up is doubtful, or when the healthcare access is limited to a certain group of patients, or a patient has lost already one eye to diabetes, and the patient is one-eyed, impending cataract surgery and pregnancy. I'll just take in 2 minutes. Panretinal photocoagulation is usually done by slit lamp based or indirect ophthalmoscopy based systems. So these are the images showing the slit lamp and IDO based system. So the laser around 1,500 to 2,000 laser spots are given on the retina in the mid-periphery and periphery. Around 200 to 500 micrometer size is the spot size, and it's to be on one burn width apart. The protocol S established the non-inferiority of ranibizumab in treatment of PDR. However, in the real world scenario, we can't give anti-VEGFs for treatment of PDR, but it can be given to reduce the vascularity. The surgical management. The goals of surgical management is to remove the media opacities, to allow completion of PRP so that the VEGF load reduces, to relieve the retinal traction, to achieve retinal reattachment, and to remove the posterior hyaloid phase. The indications of vitrectomy are severe non-resolving VH, dense premacular hemorrhage, tractional RD involving the macula, and refractory DME. The timing of vitrectomy, early vitrectomy is preferred in view of surgical safety and benefits of early intervention. The adjunctive role of anti-VEGF agents these days in certain difficult cases where the vascularity is too high, we usually give anti-VEGF agents to prime the eye before surgery so that during the surgery the bleeding is minimal. Thank you.
Thank you, Dr. Arun. That was very comprehensive considering how vast the topic is. Next, I would like to call on stage Dr. Elizabeth, who's come here all the way from Little Flower, Angamali, for the talk on how to evaluate a case of squint.
Good morning, everyone. I bring greetings from Kerala, and I thank the Bangalore Ophthalmic Society for inviting me here to present a talk on evaluation of strabismus. See, evaluation of strabismus is an art. It requires time and patience. You have to have good observational and analytical skills, and we have to adhere to certain protocols. Of course, starts with the history. You have to ask the patient when did it happen, is there any history of neurological deficits, is there any history of trauma, is there family history, like that. It starts with history, then inspection, Then we do vision examination and sensory evaluation first before we do the motor evaluation. Cycloplegic refraction is mandatory. Of course, routine anterior and posterior segment evaluation, and then we'll come to special tests. See, when you inspect a child, look at the head posture. Head posture, abnormal head posture has got 3 components, remember. It has got a face turn, head tilt towards the right or left, or chin up and down. See this child. See, the first child has got a face turn and a chin position. This child has got a chin up position. So when a child comes with abnormal head posture, you have to assess the child in the assumed natural position and also keep the head straight. Keep the head straight and assess the squint again. Coming to assessment of vision, I am not going into detail. It depends on the age of the child. Starts from central steady maintained fixation, whether fixing and following, and 2 preferential looking tests, the Cardiff test, the Teller test, the different picture cards, all depends on the age of the child, which is out of, in this talk it cannot be covered. Then we have to do the sensory evaluation. We have to look at the stereopsis and fusion. To have the stereopsis test, we have the different tests. I just go through that, the names only. The TNO is there, the Titmus test, the Lang's test, and all those tests are to be done first and assess the stereopsis before we do the motor evaluation. Fusion has to be assessed either with the Bagolini or the Worth-Fodor test. I'm not going to the details because everyone knows how to do a Worth-Fodor test. It's a very useful test and has to be done in every patient. Coming to the motor evaluation, it can be done first. Before doing the motor evaluation, you can have a rough judgment about the angle of the deviation by looking at the corneal reflex. That is otherwise known as the Hirschberg test. You shine a torchlight in front of the patient's eye and look at the Purkinje images in relation to the pupil. If it is in the center of the pupil, there is no deviation. If it is on the side of the pupil, on the temporal side, it's an isodeviation. If it is on the nasal side, it's an exodeviation. Similarly, up or down. And you can quantify it for about 1 millimeter of deviation. The deviation will be about 5 to 7 prism diopters. So this is a very crude test, but it's always helpful. And after that, we come to the cover test. The patient is asked to look at an accommodative target. For near, you have to have a picture card, or for distance, the Snellen's chart, and always cover the fixing eye first. You cover the fixing eye first. See, in this child, the left eye is squinting. You cover the good eye first and see the position of the squinting eye. If it comes to take a fixation, that means the patient has got reasonably good vision, and if it comes out to take a fixation, it was an isodeviation, like that. If the patient is not able to move the eye to take a fixation, then there is the chance that the vision is so little, gross amblyopia, or is an eccentric fixation, or is a paralytic squint. After the cover test, we do the uncover test. Here in this patient, reasonably very small deviation, and when you cover, you make sure that the other eye is fixing, and when you remove the cover, watch the eye undercover. Now the eye undercover is deviated very much outwards. That means the patient has had a phoria. Here, you get the tropia here. Here the entire phoria is unmasked. That is the importance of uncover test, which has to be done for both eyes, for near and distance. Then comes the alternate cover test, which will mask both the phoria and tropia. You cover the eyes relatively fast, and all the time you cover either one eye or the other, and this will bring about the entire total deviation, the manifest deviation and the latent deviation together. And then we go ahead with the different prism tests. All the prism tests have to be done with and without glasses, both for near and distance, and has to be done for all gaze positions. The most commonly done prism test is the Prismba cover test, which we usually say as the PBCT. This is how you do the PBCT or the prism bar cover test. This can be done with the prism bar or with loose prisms. You cover, you put the prism in front, an approximate prism in front of the deviating eye, and then you cover the other eye and see whether the deviation is corrected or not. If it is not corrected, increase the prisms. Like that, increase the prisms till and do the cover in between and make sure that the deviation is fully corrected, and that will give the amount of deviation. This is called a PBCT, alternate prism and cover test. And alternate prism cover test give you the total deviation, whereas the simultaneous prism cover test, where you cover the you put the cover and the prism simultaneously, that will give you the manifest deviation. The simultaneous prism cover is important in accommodative esotropias, where you want to see only the manifest deviation. Also look for distance near disparity and pattern strabismus. If there is a deviation is different for up gaze and down gaze, then it is called a pattern deviation. You have to check the deviation 25 degrees up and 35 degrees down. For V pattern, you have to have at least a 15 prism diopters difference, and A pattern 10 prism diopters. In those people who you cannot do a PBCT, we do the Krimsky. In those people where the vision is too low to produce an accurate fixation, you do the Krimsky. In a normal Krimsky, you keep the prism over the normal eye. And if the vision is too low in the other eye to take a fixation, you can put the prism in front of the deviating eye and put the prisms in increasing strength to make the deviation central. That is the modified Krimsky. 2-3 things which we have to remember doing the prism cover test, prism test. You should not put two horizontal prisms together. That will add that will give an incorrect reading. And also when you are doing a measurement with the spectacles, remember that the spectacles have got a high plus or high minus lenses has got the effect of a prism, and your reading may be wrong. There are nomograms in textbooks, and so you have to apply the nomograms before taking the accurate deviation. Now the next comes the extraocular movements. We have to do the uniocular movements and binocular movements. Uniocular movements are otherwise called adduction movements. This is abduction, adduction, extorsion, intorsion, supraadduction and infraadduction. Those are the uniocular movements. See, the importance of uniocular movements is seen in this picture. See, in this child, when both eyes are open and the patient is asked to look at this torch kept on the lateral side, on the temporal side, the eye is not moving. So also on the other side, on the left side also, when the torch is kept and ask the patient to look at that direction, the eye is not moving. But when you cover the eye and make the child look laterally, the eye will come towards the lateral position. That means this is due to disuse. And so when there is a defective movement, you always have to look for the uniocular movements. Coming to binocular movements, you have to have the measurements in all 9 cardinal positions, and you have to document. Documentation can be done in different ways. See, this patient has got a primary position deviation is very small, so this is only 10 prism diopters in the primary position, whereas in up gaze, there is because of the inferior oblique overaction. This is the inferior oblique overaction. You can see on up gaze, the deviation can be documented like this, and on sideways, the deviation is more. It is about 45 prism diopters. So you can document, and this patient has got inferior oblique overaction, which is documented as 3+ on the up gaze, up and in position 3+. Other moments are documented as 0. 0 means normal, plus means it's overaction, and minus means underaction. And since this patient has got a V pattern, so the V pattern also can be documented like this. This is the perfect documentation of a strabismus patient. See this patient, again, the primary position is only divergent squint, and on up gaze you can see the inferior oblique overaction, and this is a V pattern. This is the post-op picture. Again, this child, primary position was okay, but when the patient is looking at the sides, you can see gross retraction of the globe, and an upshoot and a downshoot occurring in the same patient. You can see the downshoot also here. So this is a typical Duens. So looking at the ocular movements, you make a diagnosis. And after that, you have to have so many special tests there. Parkes 3-step test is important in cyclovertical analysis, muscle analysis. Double Medex rod to assess the torsion. And this is how you do the Parkes 3-step test. First you assess the deviation in the primary position, then you have to assess the deviation by turning the head to one side, this is, you take the primary position. Now you turn the face to one side, take the deviation, then again you turn the face to the opposite side and measure the deviation, and then you have to have the deviation measured in right and left head tilt. This is very important in a cyclovertical muscle palsy. See, this patient originally has got a head posture and the right hypertropia. This was an old superior oblique palsy which got decompensated and resulted, and now the prominent feature is a superior rectus overaction. So this is the measurement you are taking in the face turn position. The patient is looking at the Snellen's chart, and then you tilt the head like this and take the measurements again. That is how you do the Parkes 3-step test, which is important in cyclovertical. And to assess the torsion, we have two methods. One is the Medex double rod test, like this. You put the two Medex rod, show the slit, and see whether there is a separation. Or you can have an objective measurement by looking at the fundus, either by the indirect ophthalmoscopy or the fundus picture. You will look at the position of the fovea in relation to the disc. Usually the fovea is situated in the lower part. If you draw a line from the center of the disc, this is fovea will be situated in the lower part. Here it is much down. That means there is an extorsion. Force duction test and force generation tests are important in case of a paralytic squint. Diplopia charting to measure the diplopia, and this is how you have the patient has to wear a red and green glass, and then a torchlight with a slit is shown, and the patient is asked to describe the position of the two images, just like that. You shine the torchlight in all different directions, all the 9 cardinal positions, and ask the patient whether the two images are seen close together or widely separated. And then depending on the patient's you can see here the patient is seeing double in that side. That's a horizontal muscle palsy. Then you record it. And then other important tests, I'm rushing through this because of time problems. And you have to have the 10 prism base down test. 10 prism base down test we do to assess fixation in a small child, and 4 prism base out test in monofixation syndromes. In DVDs you do prism undercover test. I think the time is over. I thank the Bangalore Ophthalmic Society again. Thank you very much for a patient hearing.
Thank you, Dr. Elizabeth. See, she's almost covered the whole textbook. I'm telling you, because so much to learn. If a PG has to digest and keep that kind of information ready in the head, it takes about a year. See, it's not easy to learn squints without guidance, and every PG should take a case that has got a palsy or a comitant squint and do the test for themselves. There's no way you learn squint just by listening, or these days I find even reading has come down so much drastically. They don't want to read. Some internet presentations are there, they come up with that. So please, the amount of time you dedicate to reading is what you digest and keep it in memory. Okay? So it's a question bank that you have in the examination hall, but apart from that, practical things, what she has described is beautiful. Thank you, ma'am.
Thank you so much for that, ma'am. Thank you, Manju, ma'am. Now, next, I'd like to welcome Dr. Pinto Kiran for his talk on proptosis and how to approach a case of proptosis. Thank you so much.
Very good morning, everyone. I would like to thank BOS for this wonderful opportunity. We know that proptosis is a very big topic. It's very difficult to cover in depth, but we'll just, we will get just a glimpse of it, and we'll go through what are the things we must do in a case of proptosis. So proptosis, the history, when you are taking a history, it has to be like a general and specific history, particularly related to the proptosis. Then we define proptosis as a forward protrusion of the globe in relation to the skull, which is measured from the apex of the cornea to the outer orbital rim. There are two ways to measure it. One is, the bedside test. That is a worm's eye view, where you ask the patient to elevate the chin, look up. You compare the corneas of both the eyes. If there is any proptosis, you can make out. Similarly, you stand behind the patient, ask the patient to look forward, and if you are able to see the cornea of any on one side, then there is a proptosis. That is known as a bird's eye view. So then we have something known as a quantitative measurement of the proptosis. We have different varieties by which we can measure the proptosis. The widely used one is a Hertel's exophthalmometer. So the exophthalmometer is very important, especially when you are treating any cases medically. So that requires, one is a baseline, the reading. That is the the average distance between the lateral orbital margin where you place the exophthalmometer, and similar to the visual acuity, you need to mention how much is the amount of proptosis in both right and the left eye. So the other thing is, you need to differentiate proptosis from a pseudoproptosis. What is the pseudoproptosis? There is apparent proptosis. It's either due to any bony abnormalities like a Cruzen syndrome, or maybe shallow orbital volume, or it could be because of enophthalmos on one side appears to be the proptosis on the other side, and it could be because of a high axial length also. So coming to the examination part, in the examination, look for any facial asymmetry, especially on the side of a proptosis. Similarly, look whether the patient has proptosis, what type of a proptosis he or she has, like whether it is axial proptosis. Axial proptosis, when the eyeball is moves forward along the visual axis, along the central axis. The examples are thyroid eye disease, any mass which arises within the any intracorneal lesion can give rise to axial proptosis. Abaxial proptosis, anything outside the cone, especially the lacrimal gland tumor, or it could be from the sinuses, anything which causes the proptosis. Then look for, is there any periorbital fullness, especially the infiltrative lesions will have a periorbital fullness. Look for any skin changes, especially a long-standing ones or vascular lesions can give rise to the skin changes. Look for the lid position, and whether it is a ptotic or is there any lid retraction. Similarly, look for the surface of the tumor, whether is it necrotic or it's causing any bony destruction. You need to look for these things, very important. Look for the conjunctival sac also. Sometimes that, especially on a slit lamp examination, that will give you a better picture. Next, if you suspect any vascular tumor, then perform, Valsalva maneuver, that will give you whether the patient has any low flow type or anything like that. Next, in the palpation, the important thing is you need to confirm your inspectory findings. And the important thing is, one should not forget the ocular examination. One has to do the ocular examination, especially like, for example, a case of keratoconus fistula, where you have to do the patient can have a secondary glaucomas. You have to do a fundus examination and clinical examination. Similarly, a patient having a neurocysticercosis, you have to do a fundus examination. Systemic examination is a must, for example, in a case of neurofibromatosis. And what are the investigation? We do all investigation. The important thing is USG, wherever it's available, you can do it for all the patients. And CT has to be avoided, especially in a case of retinoblastomas. Excision biopsy or incisional biopsy has to be done only once you have done the CT scan. FNAC can be done, and it should be avoided, especially in a pleomorphic adenomas, hydatid cyst or a dermoid cyst. And peripheral blood smear has to be done in a case proptosis in a child. And MRI has to be done in all cases. MRA, magnetic resonance angiography, has to be done when you suspect a vascular tumor. So the various presentations could be like bilateral proptosis. The examples are in adults, thyroid eye disease, lymphoproliferative disease, cavernous sinus thrombosis. In children, the most common ones are leukemia, neuroblastoma, orbital cellulitis in a later stage. And coming to some of the examples for proptosis at birth, we have encephalocele. There is a dehiscence of the bone, and that can give rise to, the herniation of the brain tissue. Then you have a teratomas, which is present since birth. Capillary hemangioma, sometimes it might be present since birth, and majority of the time it presents after, just 1 month after birth. Similarly, you should have a differential diagnosis for acute onset proptosis in children, orbital cellulitis, rhabdomyosarcoma, lymphangiomas, and leukemia. So you should do a investigation relevant to that. Especially you have to do, the CT scan. That will give better picture. And rhabdomyosarcoma, again, you should be able to do imaging. And lymphangiomas, in the imaging, you should be able to appreciate the air fluid levels. And leukemia, in the leukemia, the important thing is it's an infiltrative kind of a lesion. It molds around the globe, and you don't see any denting of the globe. And you starts with the unilateral involvement, followed by there will be bilateral involvement. And axial proptosis, you should know the differentials are thyroid disease, cavernous hemangioma, and anything which is within the optic nerve tumors can give rise to axial proptosis. These are some of the examples and the clinical pictures. And in meningiomas, you should be able to examine the pupillary reflex, and followed by the fundus examination that help us to cleanse the diagnosis of a meningiomas. And optic nerve gliomas, and especially the painful orbital, painful proptosis, the two important differentials are, one is a pseudotumor and a thyroid eye disease, and you should know how to differentiate by imaging and also by the clinical examination. So the other two important abaxial proptosis tumors which are very commonly that needs to be differentiated are the lacrimal gland tumors. One is a pleomorphic adenoma, and other one is a adenoid cystic carcinomas. And in pleomorphic adenomas are usually, majority of the time, it's a painless lesion, and if it is adenoid cystic carcinoma, they will have a pain, and you should be able to make a diagnosis based on your imaging and bony destruction. And you should be able to, especially for a vascular lesion, you should know how to differentiate, whether it is a type 1, type 2, or a type 3. Type 1 is also known as a no flow, and the type 2 is also known as a low flow, and type 3 is known as a high flow vascular lesions. And you should know how to differentiate based on the presentation. And this is one of the example. This patient had vascular lesion, which was, in the beginning, it was very small. Day by day, it was keep increasing. And CT angiography was done. It showed there is a abnormal vessels communication between the superficial temporal artery and the internal carotid artery. And digital subtraction angiography showed there is a lesion. Then it was embolized. And once the embolization is done, you need to remove the tumor that has to be sent for histopathological examination. So the take-home message is a thorough clinical examination and a relevant investigation will yield a good results in all cases. With this, I conclude. Thank you.
Very beautiful pictorial presentation.
Thank you.
I think we can remember very well like this. Thank you.
Thank you so much, sir, and thank you, Rama ma'am, for that. Next, I'd like to invite Dr. Shirja for her talk on enigma of the edematous disc, or the differential diagnosis of disc edema.
Good morning, everyone. Thank you. I would like to thank BOS for giving me this opportunity. My topic given to me is enigma of edematous optic disc. So what is enigma? Enigma is a subject which is complex or probably difficult to understand. So as it is a PG session, I think some of the postgraduates are there here. One of the commonest emergency fundoscopy call you get is to rule out papilledema. Either it is from other departments, usually you get from before doing LP, or from OBG department, usually they want to rule out papilledema. Okay, so this complex subject, I want to make it simplified. So for this, you need to know what is a normal optic disc first. So what are the structures you see to call it as a normal optic disc? Usually the size, shape, of course, and color. Usually it's pink in color, and the margins, whether they are clear, distinct, sharp margins, and the cup, and the CD ratio. These are the parameters you see. Cup disc ratio, again, there can be physiological variations, but in papilledema, usually you see a complete obscuration of the optic cup and the neuroretinal rim. So neuroretinal rim, usually the color of the neuroretinal rim is more important in papilledema. And the vessels, how are the vessels? Whether the vessels are obscured or crisply seen. And what about the peripapillary area? What do you mean by peripapillary area? It is the area which is surrounding the optic disc. So if there are any changes like hemorrhages and exudates and the blurred disc margins, then definitely we can diagnose it as papilledema. So these are some of the terminologies. What is optic disc edema? So any disc edema which is true disc edema is due to any other cause is called true optic disc edema. So what is papilledema? So one of the commonest thing due to raised intracranial pressure. So what is pseudopapilledema? Pseudo is the terminology used for, it mimics a true papilledema, but it is not a true papilledema. So what are the causes of pseudopapilledema? So any guesses for this image? If the image clarity is good, it is optic disc drusen. It is one of the differential for pseudopapilledema. Second image, yeah, morning glory syndrome. Third one, it's pretty simple, myelinated nerve fibers. It is a tilted, the image clarity is not so good, tilted optic disc. So before you venture it, put it as a true optic disc edema, you need to know what are the causes of pseudopapilledema. So how do you differentiate? As I told you, the vision usually is not affected in papilledema, even in the advanced stages. Later stages is affected. Otherwise, vision is equal in both the sides, both papilledema and pseudo. Pupillary reactions also are not usually affected. Optic cup is the one thing which is totally obscured in papilledema, and patterns, lines, and associated peripapillary retinal hemorrhages which are seen in papilledema, which is not seen in pseudopapilledema. So in this image, you can see the first image having obscuration of the vessels, hemorrhages, and in second image, you can see there is no obscuration of blurring of the vessels, and no associated features of hemorrhages or exudates. So first one is true papilledema, second is pseudo. So how do you approach a case of disc edema? First thing you have to remember is you should examine both the eyes and then differentiate it whether it is unilateral or bilateral. So when you see bilateral disc edema, again you have to rule out whether it is pseudo or true edema. Then if it is papilledema, of course, you know the course. Then the most common systemic cause which can cause bilateral papilledema again is grade 4 hypertensive retinopathy, you have to rule out. It's a simple BP can do the thing. And bilateral papillitis, compressive optic neuropathies, and other causes. So when you see these bilateral things, always remember, do a systemic and thorough neurological workup. And when you see unilateral disc edema, again you have to see whether the disc edema is pale or hyperemic. If it is hyperemic, usually it is papillitis. Again, these are all not dictums. You have a series of differential diagnoses keeping in mind based on your findings. And AON and CRVO and papilledema can be asymmetric. Initially you can find in one eye, and later on also it can develop in other eye. That is the reason always examine the other eye also thoroughly. Even the early disc edema should be picked up in the other eye. So pale disc edema is a characteristic feature of AON. So this I think all of you know, Frisson grading of papilledema, grade 1, 2, 3. Based on this, you have to know whether it is early papilledema or established papilledema. This is what they expect when you get the references. So whether it is early or established papilledema. So coming to grade 4 hypertensive retinopathy. So here you see the disc edema, along with that there are associated all features of other hypertensive changes, multiple hemorrhages, cottonwool spots. So this you can't miss, and most probably it is bilateral. And diabetic papillopathy, this can often be confused by the residents thinking it to be sometimes NVD. So some of the residents do think it is like an NVD, but it is again, it can be differentiated easily. So coming to optic neuritis again, two things which you have to think to differentiate between optic neuritis and papilledema. One is reduced visual function and RAPD. And the edema is less severe than you see in the papilledema. So this is very characteristic question, everybody knows this, Foster-Kennedy syndrome. So frontal lobe meningioma compressing causing optic atrophy in one eye, other eye having disc edema. What is pseudo-Foster-Kennedy? In the image it is showing one eye having optic atrophy, other eye having disc edema. It is mimicking the Foster-Kennedy. But what is the most commonest cause is sequential non-arthritic AON. One eye has already had an episode, then it is a pale, disc is pale, the other eye is having a sequential after some weeks. So that is mimicking a Foster-Kennedy syndrome. So again, I'm not going to detail of all these things. You have arthritic and non-arthritic AON, as I told you. In arthritic, the characteristic feature is hyperemia of the disc with edema, whereas in arthritic, you see pallid disc edema. And the visual loss also is more severe in arthritic. And vascular occlusions, you have non-ischemic, ischemic. Again, in this ischemic, you find a lot of disc edema with other hemorrhages. Some of the hereditary optic neuropathies and even toxic nutritional optic neuropathies, these are all the causes for disc edema. This is one of the important cause, diagnosis of exclusion. Never ever do a conclusion like IIH. IIH is a disease which has to be ruled out by doing neuroimaging and CSF analysis and doing all sort of investigations. You don't find anything except papilledema, and you have an elevated opening pressure of the CSF. So it is most characteristically seen in obese young females. And investigations, usually you do it, not that it will help in diagnosis, but definitely in some conditions like AON, you have a typical altitudinal defect. Papilledema usually has an enlarged blind spot. In other optic neuritis, of course, central and centrocecal scotoma. And B-scan also, these all help in aiding of the diagnosis, but the main diagnosis is already done by the clinical thing. You can see a crescentic shadow just behind the retrobulbar optic nerve. And in a transverse B-scan, you can see that crescentic sign. Other imaging, neuroimaging, of course, you have to do MRI to see for in characteristic Dawson's finger, you see in periventricular plaques, you see in MS, and empty cella in IIH. And definitely you have to rule out not just MRI, MR venogram to look for cerebral venous thrombosis. And necessary investigations, like some of the blood investigations which are very important are ESR in AON and blood sugars for diabetic papillopathy, hypercholesterolemia, and polycythemia. And as I told, that CSF analysis, opening pressure, and to rule out meningitis also, it's very important. So the take-home message for all the residents usually is, never ever conclude just by seeing a disc image. Always take a brief history, why they have referred the patient, what is the history, visual acuity, color vision, RAPD, ocular movements, and fundus picture. Then you have to come to a diagnosis based on all the features. Then relevant investigations also, only relevant investigations you have to do, like neuroimaging, blood investigations, and lumbar puncture. And then, of course, your treatment depends on your diagnosis. So, thank you, ma'am. Hopefully it is demystified, the enigma. Thank you.
Thank you, ma'am. It was quite nice. Like all the pictures were put, and it's a good presentation.
In the interest of time, we'll just quickly move on to the next speaker. I welcome on stage Dr. Venkatesh for his talk on how to approach a case of ptosis.
Good morning, everyone. I would like to thank BOS for giving me this opportunity. It's a very vast topic, but I'll try to cover as much as possible. Ptosis is defined as abnormally low-lying upper eyelid margin with eye in primary gaze. So approach would include history, clinical examination, investigations, and then management. History presenting complaints, commonly it will be drooping of eyes, sleepy or tired appearance, constriction of visual fields, or constant chin-up position. Onset of ptosis, we'll come to know whether is it congenital or acquired, progression, aggravating or relieving factors, diurnal variations, history of repeated lid swellings, especially to rule out blepharochalesis, history of trauma for orbital fracture or third nerve palsy, any ocular surgeries, family history, past history of any cancers, any bleeding disorders or anticoagulant use, family history of malignant hyperthermia or cardiac disorders. On physical examination, mainly visual acuity, refraction, head posture, particularly you can see that chin up. Because of ptosis, child or adult will try to have a chin up position. Frontalis overaction, one can make it out. Proptosis or inophthalmos can present as a pseudotosis, extraocular movements. Skin changes, lid tumors, mechanical ptosis can be there. Lid position, quantification and qualification of ptosis. Conjunctiva for signs of any inflammation, mainly to rule out inflammatory causes of ptosis. Cornea for signs of any dry eyes and sensation. Iris and pupil for heterochromia and anisocoria. Fundus evaluation should be important. Quantification of ptosis, head posture, frontalis overaction, palpebral fissure height, marginal reflect distance 1 and 2, I'll show everything. Lid crease, lid fold, levator function, very important, lag of thalamus and Bell's phenomenon. These three things decide for your surgery. Tear dysfunction, corneal sensation. Head posture, frontalis overaction, one can clearly make it out. Palpebral fissure height, this makes amount of ptosis also. Marginal reflect distance, that is from pupil to upper lid margin 1 and lower lid margin it is 2. Lid crease distance from lid margin to the crease and lid fold distance and LPS function. Always occlude the brow overaction, then you will get the actual amount of LPS function. Bell's phenomenon is very important because poor Bell's, one of the contraindication for your ptosis surgery. Lag of thalamus, pre-existing, then post-ptosis surgery, there will be more lag of thalamus. One has to be very careful and explain clearly to the patients. Marcus-Gunn-Jaw winking phenomenon. Video is not playing. Marcus-Gunn-Jaw winking phenomenon is very important because it entirely changes your action of surgery. Qualification, is it congenital or acquired? Under congenital, simple ptosis is very common. With superior rectus weakness, synkinetic ptosis like Marcus-Gunn-Jaw winking ptosis, misdirected third knob ptosis, blepharophimosis syndrome, Horner syndrome, Duane's retraction syndrome, Kern-Sarre syndrome, and congenital third knob palsy. Acquired ptosis, you have aponeurotic ptosis, which can be senile and other things, neurogenic ptosis, third knob palsy mainly, myogenic ptosis, myasthenia gravis, ocular myasthenia it can be sometime, traumatic ptosis and mechanical ptosis. This is blepharophimosis syndrome, traumatic ptosis, senile ptosis, aponeurotic ptosis. You can see that skin is very, very lax here. Due to blepharochalesis, similar thing in a young individual. Post-inflammatory because of papillae on the upper lid, repeated vernal keratoconjunctivitis can cause such things. Misdirected third knob palsy, third knob can also have ptosis. Mechanical ptosis, plexiform neurofibromatosis. Horner syndrome can have meiosis with ptosis, mild ptosis. Third knob palsy, usually the gaze will be in the lateral gaze. Investigations, mainly relevant investigations for surgery, Tensilon test to rule out ocular myasthenia, neuroimaging to rule out any intracranial causes. Management, non-surgical, using crutch glasses or treatment for ocular myasthenia. Surgical would be LPS resection, LPS plication, mullerectomy, or frontalis sling surgery. This is decided based on the amount of LPS function, the amount of ptosis, and other things. Non-surgical, like crutch glasses, can be prescribed if surgery has to be delayed or for some other reasons. Video is not playing. Video is not coming. This is an LPS resection or plication. Go to the folder. LPS plication here. First one you can just click it. Not playing there.
Venkatesh, if you can play it separately in the video, you can do
Yeah,
that.
yeah, yes, sir. Same thing I'm doing. Skin incision is made after this thing. Deep dissection is continued inside. in the above the tarsal plate as well as superiorly. Orbital septum is identified. We inject generally at the tarsal plate to have a separation between conjunctiva and LPS. Orbital septum is separated. Then the orbital fat, we can see it. Below the orbital fat, you have the LPS. And between conjunctiva and LPS, either plication or LPS resection is done for this thing. Central, medial, and temporal sutures, we generally put it. And skin is closed. This is a congenital simple ptosis, pre and post. Always explain this to the patient before surgery. After ptosis surgery, they will have more prominent lag of thymus and lid lag. Frontalis sling surgery, whenever there is poor LPS function, we do the frontalis sling surgery. I'll skip the video. This is how the post-surgical results. Very excellent in primary gaze, whereas in down gaze and lag of thymus are very, very prominent in frontalis, this thing. Using silicone tube or Gore-Tex, we can achieve better thing. Summary, identify the cause of ptosis, check LPS function and Bell's phenomenon, rule out Marcus-Gunn jaw winking ptosis, decide on medical or surgical options, and explain post-operative outcomes. Thank you.
Dr. Venkatesh, you did a plication of the LPS, or was it an elevator advancement plication? Okay, thank you.
Thank you.
Just remember, if you do a excision of the LPS muscle, you have to do a good length, because otherwise it doesn't work. Usually textbooks say around 22 millimeters. Up to 24, even 26 is done. So little overcorrection may be initially, but it does respond to a good surgery if you follow the proper, tissue planes. And even if you have a little bit of lag of thymus, patient is very happy because whatever was there initially, that gets corrected after the surgery. Cosmetically, it's a very good surgery. Function-wise also, it's a very good surgery. Thank you.
For postgraduates, measurement is important, and learn a proper technique of measurement, because you may be asked to demonstrate and things like that in the exams.
Thank you so much, sir.
Thank you, sir.
Next, I invite our last speaker, Dr. Raksha, a senior consultant in Netradama, for her talk on examination of a case of glaucoma.
Welcome. Good morning, everybody. I'm thankful to BOS for giving me this podium. My topic for discussion today is examination of a case of glaucoma. As we all know, glaucoma is a group of eye disease in which the optic nerve is damaged because of increased intraocular pressure and causes peripheral visual field defect. We'll go step by step, starting with preliminary examination. Coming to history taking, asking for chief complaints is very important. Ask for history of decreased distant vision. Ask whether it is a sudden onset or a gradual onset. Ask for frequent change of glasses. Ask for history of pain and photophobia with colored halos, which suggest of acute angle closure glaucoma. Ask for history of trauma, history of use of steroids in any form for longer durations. Coming to systemic history, it is important to ask for history of hypertension, diabetes, family history of glaucoma is important. Rule out autoimmune diseases. Recent studies have also said that sleep apnea syndrome causes open angle glaucoma. Ask for history of smoking and alcohol. General examination of the patient is important to rule out autoimmune diseases, also for syndromes like Marfan's Weil-Marchesani syndrome as well as phacomatoses. Coming to ocular examination, check for the vision and refraction. If the patient is myopic, he is prone to have an open angle glaucoma. Hypermetropes are more prone for angle closure glaucoma. Slit lamp examination, check the lids. In conjunctiva, look for circumciliary congestion for acute congestive glaucoma. Look for corkscrewing of the vessels to rule out CCF. In the cornea, you can look for Krukenberg spindle for pigmentary glaucoma. Look for keratic precipitates for uveitis, rupture of Descemet's membrane, and Habstrite for congenital glaucoma. Also, thinning of the sclera is seen in congenital glaucoma as well as absolute glaucomas. Coming to the most important thing, anterior chamber depth. It is normal in cases of open angle glaucoma. shallow in cases of angle closure glaucoma, as well as some types of PXF glaucomas. Various methods are used to check the anterior chamber depth. Van Herrick's classification is the most commonest, which we use in the OPD. Here, the test is done on the slit lamp by oblique illumination. We compare the peripheral anterior chamber depth with the corneal thickness, and we grade it accordingly. Another test which can be done in the OPD by the PGs is oblique flashlight test, in which a light is shown from the temporal side parallel with the iris, and amount of illumination represents the anterior chamber depth. So on the other side, if you see all the structures and the iris, that means it is open. If you see a shadow, that means it is a shallow AC. In the iris, look for atrophic patches, posterior synechiae, peripheral anterior synechiae. Look for neovascularization of iris. Look for iris holes. Check for the patency of the PI. Also check for the pseudo-exfoliation, which can be present on the iris. Pupil, we see sluggish reacting oval pupil in cases of increased intraocular pressure. Afferent pupillary defect needs to be checked. If it is unilateral, it is suggestive of advanced glaucoma in that eye. Coming to the lens, you have to rule out whether it is a phacomorphic or a phacolytic glaucoma. Check for pseudo-exfoliation material on the anterior lens capsule. Also see for glaucoma flecken, which is suggestive of acute angle closure glaucoma, which is suggestive of lens epithelial necrosis. Check for pigments on the lens, which is suggestive of pigment dispersion syndrome. Coming to the most important point, you have to check the disc. In the disc, you see for focal changes on the disc, which is suggestive of focal neuroretinal rim loss. Type of disc are different. It could be a myopic disc with glaucoma. Check whether it is a senile sclerotic disc. Another vascular or blood vessel signs which are seen on the disc are bearing of the circumlinear vessels, overpass cupping, bayoneting sign, and exposure of the lamina cribrosa. Check for the paripapillary changes like the alpha zone and the beta zone. Both are increased in case of glaucoma. Retinal nerve fiber layer defects needs to be checked. It is checked with the red free or the green filter or the green light which is seen on the slit lamp. Two types of defects are visualized. It could be either a slit defect or a wedge-shaped defect. Next, coming to the intraocular pressure. The normal intraocular pressure range is between 10 to 21 mm of mercury. These are the commonly used tonometers, out of which Goldman's applanation tonometer is the most popular and accurate tonometer. We have to explain the procedure to the patient, and we have to anesthetize the eye of the patient with a topical anesthesia like Paracaine. The cornea and biprism are illuminated with a cobalt blue light from the slit lamp. Then we will move the biprism forward until it touches the apex of the cornea. At this point, two semicircles are viewed through the prism. Then the applanation force against the cornea is adjusted until the inner edges of the two semicircles just touch. This is the end point. You have to make sure that the Mayas which you are seeing are neither too thick or too thin. Coming to gonioscopy, gonioscopy refers to the techniques used for viewing the anterior chamber angle of the eye for evaluation, management, as well as classification of the structures. Two types of gonioscopy are there. Direct gonioscopy, which allows direct visualization of the angle. The different lenses which are used for this are the Coppes, Barkans, and Swan-Jacobs. This type of gonioscopy is usually done while doing surgery for congenital glaucomas. Coming to the indirect gonioscopy, it utilizes the mirrors to reflect the light from the iridocorneal angle into the direction of the observer. Different types of lenses used here are the Zeiss, Posner's, and Sussman lenses. So we explain the procedure again, and while doing the gonioscopy, we have to visualize from anterior to posterior. First is the pigmented Schwalbe's line. After that comes the pigmented trabecular meshwork, followed by the scleral spur and the grayish ciliary body band. Again, various types of classifications are used. This is the most simplest and what we refer in our OPD, Schaffer's grading. Here the angle is categorized from 0 to 4. 0 means closed, you are not seeing any structures. 4 means you are seeing all the structures starting from the Schwalbe's line to the ciliary body. While doing the gonioscopy, you also have to visualize if there is any pseudo-exfoliation, whether there is any angle recession which is suggestive of trauma, cyclodialysis, whether there is any foreign body which is present, neovascularization, or any copper deposition in Wilson's disease. These were the other tests which were done in the past. Nowadays, these are not used. Various provocative tests like Mydriatic and darkroom test. Coming to the diagnostics, we have to do the visual field test examination. In this, the most commonest, test of the visual fields, kinetic and static perimetry. Static perimetry is what we are doing nowadays, Humphrey's visual field analysis. The characteristics of the glaucomatous defects are, they are usually in the arcuate area in the superior or inferior hemifield. They are asymmetrical across the horizontal midline. They are usually located in the mid-periphery, and they are reproducible. So this is the criteria which is used to differentiate between glaucoma as well as neurological visual fields. Anderson's criteria is commonly used to define the abnormality in the visual fields. We can see this. This is a printout of Humphrey visual field analysis. As we can see here, there is a superior arcuate scotoma. So this is a superior arcuate scotoma. When we are reading the visual field, we also have to look into the mean deviation, pattern standard deviation. This is helpful in classifying as well as telling us the severity of the glaucoma. You also have to look for the fixation losses, false positive and false negative errors. Anything more than 20 to 30% is suggestive of unreliable fields. These are the different types of field defects which you see, starting from a nasal step, temporal wedge defect, arcuate defect, paracentral defect. And in advanced glaucoma, you also see a generalized constriction field of vision or a tunnel vision. There are other different imaging techniques for optic disc and RNFL evaluation, like the HRT, GDX, and OCT. OCT is used for RNFL analysis, and it helps to identify the early or the pre-perimetric glaucoma. Also, another most important thing which you need to check is the central corneal thickness, as thicker corneas produce falsely higher reading, while thinner corneas can produce falsely lower readings. So based on the intraocular pressure, as well as the other diagnostic modalities, we can classify the glaucomas and we can treat them accordingly. Thank you. My topic was very fast, so I had to rush through the slides.
Thank you. Originally a textbook, but I was worried where the next speakers would have come, and we have to have the hall ready for the oration. And thank you very much. It was a beautifully covered topic.
Thank you, Dr. Raksha. I thank all the speakers, and I thank...
If you have any questions, you ask the speakers directly, because there's no time.
Thank you, ma'am, for that. As we have already delayed the next session, I just want to quickly thank Dr. Manju and Dr. Ramadevi for chairing and co-chairing this session. If we can just proceed downstairs, with the next session will take over, we can take a picture downstairs. I hand it over to the next session.
Thanks.